Treating scoliosis in adolescents versus treating scoliosis in adults is very different. In adolescents, treatment can come in the form of, I'd say, really three things. One of those is bracing. Okay, we brace curves that are usually between like 20 to 40 degrees when they're adolescents. The other thing is vertebral body tethering. That's a newer procedure that involves growth modulation. It means that we tether the one side of the spine to let the other side sort of catch up. The third way is by doing a fusion, and this is usually reserved for more severe curves. I think the number one thing to know about adolescent idiopathic scoliosis is that the point of treatment is to prevent them getting to a high degree of curve when they're adults. So basically, there were certain studies done actually in Iowa where they followed a bunch of patients who just never got treatment for their scoliosis. And what they found was that patients who were 50 degrees at skeletal maturity, those patients tended to progress 1 degree per year into adulthood. So this means that a patient who was 18 with a 50-degree curve, by the time, 30 years down the line, so by the time they were 48, their curve was now 80 degrees. And the problem is once you get above 80 degrees, they found that above 80, 90 degrees, those patients started to have a worse quality of life, and they could even have breathing problems. So really the point of treating adolescent idiopathic scoliosis is to prevent progression into adulthood. Now, on the other hand, when an adult already has idiopathic scoliosis, so if I see an adult who's 40 years old and they have a curve that is, let's say, 52 degrees, well, at that point, it's a little bit of a different scenario because, we don't know really how fast that patient's going to progress. I mean, there's been some good recent literature presented at like the Scoliosis Research Society, actually just this past week, where they showed that, patients who are adults who have curves, between like 25 to 50 degrees, those curves can still progress. So, when I see an adult with a curve that, let's say, is like 50 degrees, so again, let's talk about that 40-year-old patient that has a curve of 50 degrees, I do think it's probably worthwhile to follow that patient to make sure that they aren't progressing rapidly. But at that point, the decision to operate, at least in my opinion, is very much based on the symptoms. So, if they're not having any back pain and they can stand normally, meaning like they're not coming off to the side or coming forward, I don't think there's necessarily a reason to do surgery for that patient. Now that's of course, my opinion, and other people may have different ones. On the other hand, if that person's at 50 degrees and then in a year, now they're at like 55 degrees, well, this means that they may be heading the wrong direction and there could be a reason to fuse that patient. You don't want them to get worse. The other reason that we a lot of times tend to end up doing surgery in the case of adult idiopathic scoliosis is because that curvature of the spine can cause nerve roots to get compressed. So, for example, if the spine is curving way off to the right, that can pinch on the right side of nerve roots, and that can cause leg pain. So that's another reason sometimes we need to treat adults with idiopathic scoliosis. But I guess my point is that in adolescence, the main point here is that in adolescence, we go a lot by the curve magnitude. So the number really matters in adolescence. Once patients get into adulthood, and I think this is, whether adulthood means 22 or whether it means, 45, I still don't think we know that, but when I'm thinking of adulthood, I'm thinking of like our 45-year-old patient. Once patients get into adulthood, the decision to operate at that point is based much more on symptoms and documented progression than a magnitude of curve alone. So, yeah.